Hi, I'm Richard. I'm a speech and language therapist and a lecturer based in the UK. In today's video, I'm going to provide a step-by-step guide how I critically appraised a randomized controlled trial using a JBI checklist. I will be critically appraising effects of effortful swallowing against kinesiology tape and resistance on the swallowing function in patients with poststroke dysphagia, a randomized controlled trial, which was written by Hwan-Hee Kim and Jisoo Park and published in the journal Medicine. In this study, the authors assessed the effectiveness of kinesiology taping combined with a technique called effortful swallowing to improve the strength of the suprahyoid muscles in patients who had dysphagia or difficulty swallowing 6 months after a stroke. I hope this video will be useful to students learning how to critically appraise research literature, practicing speech and language therapists deciding whether to include this treatment in their clinical practice, and members of the public interested to know how healthcare professionals evaluate different kinds of evidence. Let's start with a brief definition of what critical appraisal is. Critical appraisal is a systematic evaluation of research to assess its usefulness and validity to a given context. A critical appraisal checklist is a tool used to help readers with this evaluation process. Each checklist contains a set of questions designed to prompt the reader to look for certain information in the research. The number and kind of questions in a checklist depend upon the kind of study you are reading. The randomized controlled trial checklist used today asks the reader 13 questions and to answer each question yes, no, unclear or not applicable. I will now go through each of these 13 questions in turn and attempt to answer them. There will be a summary page at the end of the video with all of my ratings. The JBI checklist suggests if participants are not allocated to treatment in control groups by random assignment, then there is a risk that the assignment to the groups can be influenced by known characteristics of the participants, such as their age, which may distort the comparability of the groups. On page 2, the authors describe allocating eligible participants to the experimental and placebo groups using blocked randomization to ensure an equal number of participants in both groups. So for question 1 on the checklist, I would say yes, true randomization was used for assignment of participants to treatment groups. The JBI checklist suggests if those allocating the participants to the groups are aware of which group is next, there is a risk that they may deliberately and purposefully intervene in the allocation process. This may result in preferential allocation of participants to one of the groups and distort the results of the study. On page 2, the authors mentioned that an occupational therapist blinded to the participants completed concealed allocation using sealed opaque envelopes. This means the random allocations already generated were placed in sealed envelopes which are sequentially numbered. When a participant consents to take part in the study, the next envelope is opened and they are allocated to the group specified inside. Because the envelope is opaque, the occupational therapist cannot hold it up to the light to see the group allocation inside. So for question 2 on the checklist, I would say yes, allocation to treatment groups was concealed. The JBI checklist suggests that any difference between the known characteristics of participants included in the groups, such as their age, severity of the disease, or coexisting diseases, could negatively impact any conclusion about the effectiveness of the intervention being investigated, because any differences that are found could be attributed to the differences between the groups rather than the intervention. The checklist suggests that reviewers should check the proportion of participants with specific relevant characteristics in the compared group and not just rely upon statistical testing of the differences between groups. On page 2, the authors report that there were no significant differences between video fluoroscopy dysphagia scale and penetration aspiration scale scores between the two groups before intervention. On page 3, the authors included Table 1, which report the characteristics of the participants in the experimental and placebo groups, such as their age, gender, type of stroke, site of stroke, etc. In the final column of this table, the authors reported p-values which were all above the alpha level of 0.05, suggesting there were no statistically significant differences between the groups at baseline. So for question 3 on the checklist, I would say yes, the treatment groups were similar at baseline. The JBI checklist suggests if participants are aware of their own allocation to either the treatment or placebo groups, they may behave, respond, or react differently to their assigned treatment or placebo than participants who remain unaware of their allocation. Blinding refers to procedures that prevent participants from knowing which group they are allocated to. On page 2, the authors describe the taping protocol which was applied to the experimental and placebo groups. They described how the participants' necks were cleaned, how the tape was cut, then applied to the front of the neck, and how participants were instructed to complete effortful swallowing 50 times. This involved swallowing 5 times in a row, 10 times a day. This was repeated 5 times per week for 6 weeks. The placebo group performed the same procedure with the tape applied to the anterior cervical region and the effortful swallowing. The only difference was that the tape was applied without the 70 to 80% tension that was used in the treatment group. So for question 4 in the checklist, I would say yes, participants were blinded to treatment assignment. The JBI checklist suggests if those delivering treatment are aware of participant allocation, they may treat participants differently compared to those who remain unaware of participant allocation. We learned from question 4 about the taping protocol. The authors did not report anything about the people delivering the treatment, but given the differences between the experimental and placebo group is the tension applied to the experimental group, it is impossible for them to be blind to treatment assignment. So for question 5 in the checklist, I would say no, those delivering the treatment were not blinded to treatment assignment. The JBI checklist suggests there should be no difference between the groups in terms of treatment received other than the treatment controlled by the researchers. If there are any other exposures or treatments occurring at the same time, then the effect can potentially be attributed to something other than the treatment of interest. We learned from question 4 about the taping protocol and how the only difference was the tension applied to the experimental group. So for question 6 on the checklist, I would say yes, the groups were treated identically other than the treatment of interest. The JBI checklist suggests if those assessing the outcomes are aware of participant allocation to either treatment or control groups, they may treat participants differently compared with those who remain unaware of participant allocation. On page 2, the authors describe that an experienced occupational therapist assessed swallowing function using a video fluoroscopy. On page 4, there is a table with before and after treatment scores, so presumably a second video fluoroscopy was completed, though this is not stated explicitly. So for question 7 on the checklist, I would say it is unclear whether outcome assessors were blind to treatment. The JBI checklist suggests that if outcomes are not measured in the same way, then any differences in outcomes may be due to the method of measurement rather than the treatment. On page 2, the authors describe using a video fluoroscopy to assess and observe swallowing function. The occupational therapist then measured the swallow using the video fluoroscopy dysphagia scale and penetration aspiration scale. So for question 8 on the checklist, I would say yes, the outcomes were measured in the same way for the two groups. The JBI checklist suggests that unreliable outcome measurements may lead to errors when trying to calculate treatment effects. This question refers to the reliability of the measurement performed in the study rather than the validity of the assessments used themselves. We learned from questions 7 and 8 that an experienced occupational therapist assessed the participants' swallowing using a video fluoroscopy. Whilst the rater was reported to be experienced, there appeared to be only one rater, and no intra-rater reliability statistics were reported to show the consistency of their ratings across time. So for question 9 on the checklist, I would say no. Outcomes were not measured in a reliable way. The JBI checklist suggests that follow-up refers to the period from randomization to any point where the groups are compared during the trial. If there is incomplete follow-up of all participants, then post-assignment attrition, that is, participants who fall out of the trial, could be the reason for the treatment effect, not the treatment itself. On page 3, the authors included a consort flowchart diagram. They demonstrated that an equal number of participants were allocated to the experimental and placebo groups, and neither group suffered any attrition, so all 30 participants were analysed. So for question 10 on the checklist, I would say yes, follow-up was complete. The JBI checklist suggests it is important that participants are analysed in the groups that they were randomised to, regardless of whether they actually received the treatment or completed, etc. This concept is called intention to treat analysis and attempts to estimate the effect of offering an intervention rather than the effect of actually receiving the intervention, a small but important distinction. On page 4, the authors included Table 2, which reported the results of the video fluoroscopy dysphagia scale and penetration aspiration scale before and after treatment for the experimental and placebo groups independently, and then intergroup statistics were calculated to show differences between the groups. So for question 11 on the checklist, I would say yes, participants were analysed in the groups to which they were randomised to. The JBI checklist suggests inappropriate statistical analysis may cause errors when determining the existence and size of any treatment effects calculated. It suggests checking whether appropriate statistical power analysis was performed, if appropriate effect size were used, and if appropriate statistical methods were used given the nature of the data and objectives of the analysis. On page 2, the authors report calculating an appropriate sample size prior to recruitment, which is best practice. They set power levels at 0.6, their alpha significance level was set at 0.05, and the effect size at 0.8. They added these values into G-Power 3.1 software, which calculated that they needed to recruit at least 12 participants per group, and we know from previous questions that they over-recruited with 15 participants in each group. The value of 0.6 for power level is lower than the generally accepted standard of 0.8, which means fewer participants needed to be recruited. A lower power level increases the chance of a type 2 error, which means that there is an increased risk of failing to detect a true effect of therapy when it exists. But when a significant result is found, it is likely to overestimate the true effect size, which leads to unreliable conclusions. The alpha level of 0.05 is standard practice for significance testing in speech and language therapy. The value of 0.8 for the effect size is considered large when identifying treatment effects for groups using Cohen's d. A higher effect size increases the chance of a type 2 error, means fewer participants need to be recruited, and any significant result that is found, as above, is likely to overestimate the true effect size and lead to unreliable conclusions as a result. On page 3, the authors reported 3 effect sizes between the experimental group and placebo groups. 0.1 for the oral stage of the video fluoroscopy dysphagia scale, 0.5 for the pharyngeal stage, and 0.5 for the penetration aspiration scale. These are considered small to medium effect sizes, which demonstrates the original effect size of 0.8 was set inappropriately high. The authors also did not report any confidence intervals, which means the accuracy of these effect size estimates is unclear, i.e., will the true effect size in practice be exactly as reported, lower or higher, and if so, by how much? In a small study like this, the confidence intervals are likely to be wide. This makes it difficult to assess whether the effect sizes would be replicated in clinical practice and in future research. On page 2, the authors report using a Shapiro-Wilk test, which checks whether a sample of data is normally distributed or not. If the p-value is lower than the alpha level of 0.05, then the null hypothesis would be rejected, and the alternative hypothesis that the sample deviates from a normal distribution accepted. Therefore, a non-parametric test would likely be used instead. The authors did not report the results of the Shapiro-Wilk test, but went on to say that a Wilcoxon-signed rank test was used to compare measures in the experimental and placebo group before and after the intervention. This test is appropriate as it is used for a within-subject design, and the video fluoroscopy dysphagia scale and penetration aspiration scale are interval, non-parametric and ordinal data types respectively. The authors also reported using a Mann-Whitney-U test to compare the post-intervention mean scores between the experimental and placebo groups. This test is appropriate as it is used for between-subject design and, as before, can be used with the same data types as used with the Wilcoxon-signed rank test. So for question 12 in the checklist, I would say yes, appropriate statistical analysis was used. However, I will return to this point towards the end of the video as the result is potentially misleading and the study could arguably be rated as no. The JBI checklist suggests that typical parallel group randomized controlled trial design might not always be appropriate depending upon the nature of the question and list alternative designs which may be used instead. The RCT here used a standardised design where individual participants were randomly allocated to parallel groups. So for question 13 on the checklist, I would say yes, the trial design was appropriate. Having read the article and listened to me critically appraise it, how do you feel about it now? Did you agree with my ratings, or would you have rated anything differently? Would you consider using taping in your own speech and language therapy practice? I'm now going to share my personal thoughts about the piece and offer suggestions about how I think it could be improved. In short, I personally would consider using this evidence in my clinical practice, as taping appears to be a relatively effective, low-cost intervention that a speech and language therapist could add to their management toolbox to supplement existing approaches for the right patients. The theory behind taping, that the physical characteristics of the tape add resistance to the normal movement of the suprahyoid muscles, so the patient has to activate and recruit more muscles to overcome this tension to swallow, is theoretically sound. The suprahyoid muscles therefore increase in size and strength through repetitive practice, especially in this case where they were combined with effortful swallowing. The knock-on effect for the patient with dysphagia is that their swallow is more effective. In terms of how the study could be improved, I will give several examples. First, the level of detail in the study could be improved throughout to better describe and give readers more confidence about the methods being used. For example, the authors did not describe what kind of blocked randomization approach they used. They did not report what kind of statistical tests they used to compare the patient's demographic variables at baseline to show there was no difference between the experimental and placebo groups. They did not report how potential participants were considered for or recruited to the study, just that the sample was recruited from a local geriatric hospital in South Korea over a 6-week period. More context needed to be provided for international readers to explain why patients were still in or recruited from a hospital more than 6 months after the onset of their stroke. They provided no context for what on the surface appeared to be a relatively high number of participants with bilateral strokes and participants who suffered hemorrhages rather than infarcts, which are significantly more common in the stroke population. They also did not describe how the swallowing exercises worked in practice, or how they verified that the participants actually completed the 50 exercises per day, 5 days per week, for 6 weeks, etc., etc. I contacted the researchers to ask several of these questions and to request their primary data to validate some of the findings, because when I attempted to replicate some of the basic p-values for the demographic variables using the statistical software SPSS version 29, I had different, albeit still non-significant p-values. It's unclear why this happened. Unfortunately, the authors have not responded yet. If they respond after this video is published, I will update the description below. Second, the study would be considered a single-blind RCT because the participants were blind to treatment assignment. It's worth considering how blind the participants were to the treatment though, as presumably they visually saw and or felt the occupational therapist stretching the tape, or not, before applying it to their neck, from which they might infer which group they have been allocated to. To be more confident about this possibility, or to rule it out, it would be useful to know what participants were told about the purpose of the study and about their potential allocation to the treatment or placebo groups, i.e. were they told the researchers were interested in the effectiveness of taping in general, or more specifically the tension of the tape itself, or both. Building upon this point, the authors could have potentially developed this study into a double-blind RCT by using different occupational therapists to apply different taping tensions to different groups without knowledge of each other, so they would be blind to treatment assignment too. For practice and speech and language therapists, this approach would have been more clinically useful than testing the effect of the tape without tension against 70 to 80% tension, as the tape is unlikely to ever be used in clinical practice without tension. This might have required an additional group and a high number of participants to be recruited though. Third, the reliability of the outcome measurements could have been improved by having another professional review the video fluoroscopy recordings and rate these independently. These could then be compared against the occupational therapist ratings, and inter-rater reliability statistics could be calculated as a result to check for consistency. Fourth, whilst I rated question 12, was appropriate statistical analysis used? Yes. It is clear that the statistically significant results of this study should be interpreted with a lot of caution. The authors conducted power analysis before the study started, but the values selected for the power level and effect size were inappropriate, which allowed them to complete the study with a small sample. We call studies like this underpowered, and there is a chance that the results may not replicate if the study was done again. The authors needed to select a higher power level and lower effect size values respectively, which would mean having to recruit a larger sample of participants. Finally, whilst the authors acknowledge some limitations about not generalising the results due to small sample sizes, not measuring the tension of tape objectively, and not following up the participants to see whether the effects were sustained, a more obvious limitation is the fact that the protocol combined two interventions. Effortful swallowing is an established treatment in itself, and the current RCT design does not necessarily isolate the effect of the tape with tension. Having an additional group of participants who complete effortful swallowing exercises who do not have the tape applied will allow the researchers to identify the specific combined effect of using tape tension on top of effortful swallowing and the potential placebo effect of using tape without tension with effortful swallowing more confidently. If you found this video useful, give it a like and subscribe to receive notifications about similar videos in the future. You can also watch other examples of critical appraisal by clicking on the video on your screen now. If you've got any comments, questions, or have a request for other research you would like me to critically appraise in the future, then let me know in the comments below or get in touch with me on Blue Sky or Twitter. Otherwise, thanks for watching and take care.